Good afternoon, everyone. Today I'll be talking about a topic very close to my heart, which is newborn hearing screening. The objectives of this lecture would be to discuss the importance of universal newborn hearing screening, to describe the different newborn hearing screening devices, and to discuss the Philippine situation. In the United States, approximately 1 per 3 babies out of 1,000 babies are born with hearing loss. This is at present time, and 36 states require hearing screening of all babies. However, in the past, in the 60s and 70s, only those who were high risk for hearing loss were tested for hearing loss. This is because there were no devices then that were efficient enough or fast enough for mass screening. These are the high-risk indicators: caregiver concern regarding hearing, speech, language, or developmental delay, family history of hearing loss, stay in the NICU for more than 5 days, in utero infections such as CMV, herpes, rubella, syphilis, and toxoplasmosis, craniofacial anomalies, physical findings such as white forelock associated with sensorineural or permanent conductive hearing loss, syndromes associated with hearing loss or progressive or late onset hearing loss, neurodegenerative disorders, culture-positive postnatal infections such as meningitis, head trauma, and chemotherapy. However, if we only use the high-risk factors to test, to know which babies to test, we would be missing out on 50% of babies born with hearing loss, but who have no risk factors. Just knowing this information, it seems to be prudent to test all babies who are born. But when do we test them? At birth, at 1 year of age, preschool, school age? Studies have shown that the first 3 years of life, when the brain is developing and maturing, is the most intensive period for acquiring speech and language skills. Even more important, better language development was associated with early identification of hearing loss and early intervention. And we are talking 6 months here. They compared those who were detected to have hearing loss and intervention was done before 6 months, and those who, when intervention was done after 6 months. And there was a great difference between the two groups. When left undetected, hearing loss of any degree, including mild bilateral and unilateral, has been shown to adversely affect speech, language, academic, and psychosocial development. This is why in 1993, the NIH Consensus Development Program recommended that all newborns be screened for hearing loss before leaving the hospital. And in 1994, the JCIH, or the Joint Committee on Infant Hearing, position statement recommended that all infants with hearing loss should be identified before 3 months of age and receive intervention by 6 months of age. In 1999, the American Academy of Pediatrics endorsed the universal newborn hearing screening. They also endorsed detection of hearing loss before 6 months and intervention initiated by 6 months of age. Alongside this, new devices were being developed, which were fast and efficient for newborn hearing screening. These are the automated auditory brainstem response test, or ABR, and your autoacoustic emission test. Autoacoustic emissions are sounds produced by the cochlea in response to acoustic stimuli. There are 2 types, your transient evoked and your distortion product. The main difference between the two is that with the transient evoked, you have 1 speaker producing clicks or broadband signals, and for your distortion product, you have 2 speakers, each one producing a pure tone. This is done on the baby by placing a probe assembly in the ear canal from which tonal or click stimuli are presented, and a microphone which picks up the OAEs generated in the cochlea. This is a very fast and efficient test, taking only about 1 to 2 minutes for both ears. The result of this test would be either a pass or a refer. A pass means that the integrity of the hearing pathway up to the cochlea is intact, and refer if a rescreen is needed. Rescreen would be done with the same device, and if the final result is still a refer, then the child will need to be referred to a physician, usually an ENT specialist, to further check the ears and for additional diagnostic tests to confirm the diagnosis. Now, the other test is your automated auditory brainstem response test. You can see on the left side, you have this big bulky machine, and to the present time on the right, where electrodes are sometimes not needed anymore. The AABR is an electrophysiologic measurement that is used to assess auditory function from the 8th nerve through the auditory brainstem. Generally, electrodes are placed on the forehead, mastoid, and nape of neck. And like I mentioned previously, in some devices, you don't need these electrodes anymore. Click stimulus is presented at 35 decibels via disposable earphones. Most AABR systems compare the newborn's waveform with a template or normative ABR infant ABR results. The result again is either a pass or a refer. Again, it is fast and accurate. A little bit longer than your OAE test, maybe 2 minutes longer, but nevertheless fast and very efficient. The result again is either a pass or a refer. A pass meaning that the hearing pathway to the brainstem is intact. And if the result is a refer, a retest using the same machine or another hearing test machine may be done. If the final result is a refer, then again, referral to an ENT specialist may be warranted. Now, the main difference between the ABR technology and OAE technology is that the ABR tests the hearing pathway up to the brainstem, while your OAE tests that portion of the hearing pathway up to your cochlea. The sensitivity and specificity of ABR and OAE are also not that far apart, although we can see that the ABR has a slight edge over your OAE. Of course, with all this information abroad, research was also started in the Philippines, and our data shows that the prevalence of bilateral profound hearing loss is 1.38 per 1,000 babies born. This was done by Dr. Chong in 2007. We can also see that it is the most common congenital anomaly. It is more common than the metabolic diseases that we screen for in the newborn period, like congenital adrenal hyperplasia, congenital hypothyroidism, G6PD, galactosemia, and phenylketonuria. Other tests were also done, which pointed the way for us that newborn hearing screening was very important. And because of this, in 2007, the Philippine Society of Otolaryngology Head and Neck Surgery task force was created on newborn hearing screening. And they submitted a position paper stating the importance of universal newborn hearing screening. This was also the time when the collaboration on newborn hearing screening advocacy was started. And this is the group, along with the other groups, that pushed for mandating universal newborn hearing screening. In 2009 was signed into law by the President of the Philippines, then Act 9709. The key of this law is that these be 3 months of age, and there are also early diagnosis and definitive intervention for hearing loss. Includes the cost of hearing loss screening and its benefit and the program to gradually increase the coverage from hearing screening to diagnostic evaluation and intervention services. Another is that audiologic centers will be identified, those centers for screening only, or those centers capable of doing diagnostic testing, as well as intervention centers. Certification courses for screening technicians are also being done to train potential screening technicians. These results are sent to the Newborn Hearing Screening Reference Center based in the NIH. As of 2012, 216 individuals have been certified to perform newborn hearing screening. 83 hospitals have been found to be capable of performing newborn hearing screening across the country, and 33 hospitals have been found to be capable of performing diagnostic hearing tests. As of present, the 2014 data, we have two examples of hospitals performing universal newborn hearing screening, which means that all newborns are tested before they leave the hospital. In one private hospital, about 2,000 babies are screened per year with a 3 to 5% refer rate and a very good follow-up, a 98% follow-up for rescreen and diagnostics. In a government hospital, 1,157 were screened with an 18.5% refer rate. That is quite high, maybe because of the population of those screened, maybe they're really very sick children. And the sad news is that only 41% followed up for rescreen and diagnostics, maybe due to lack of funds or they don't understand what the procedure or the newborn hearing screening. Now, these are just the initial steps. We still have a lot of work to do. For example, after screening, the child will need diagnostic tests, like your diagnostic ABR, your auditory steady-state response, maybe pediatric audiometry, and possibly what is new today is your central auditory evoked potentials. And after that, you need intervention with the use of hearing aids, implantable hearing devices, and if this is not affordable for the family or because of their choice, they can also take sign language or total communication. Now we have other issues as well with regards to newborn hearing screening. For example, babies born at home, how will they be screened? Babies who are lost to follow up or do not show up for repeat tests or diagnostic tests, how will we make them follow up? And the next would be PhilHealth coverage for diagnostics and intervention. Talks are now on the way or ongoing regarding PhilHealth coverage for the diagnostic ABRs as well as hearing aids. Now, that ends my lecture. Thank you very much.
I will now ready to accept all your questions to Rina. The question here, Rina, are the babies screened regardless of whether they pass or fail, followed up, and how does the NIH keep track of these children?
What's the question again?
Are the babies screened regardless of whether they pass or fail?
Oh, okay.
Followed up.
So the question is, if you are talking about universal newborn hearing screening, then all babies born should be tested or should be screened for hearing loss. So all babies, unless the parent signs a waiver for this test.
Okay, thank you, Rina. Are there other questions? There's another question. Where are the schools for the deaf in the Visayas and northern Mindanao, and how are they funded? What is the status of specialized education for deaf kids?
Okay, so the question is, not in my line, but I'm not really familiar of the schools in the Visayas and Mindanao region. Although we are connected with the College of Allied Medical Professions, and if we need contacts in those areas, we ask them for this information. Also, with regards to the deaf education, I think I can ask them, the College of Allied Medical Professions. These are the speech pathologists, speech and language paths, who are our colleagues and who we deal with almost every day.
Okay, Rina. Great lecture, Rina. What percentage of newborns with hearing loss in the Philippines need a cochlear implant?
We mentioned before that the prevalence of hearing loss is about, the profound hearing loss is 1.3 per 1,000. For those with profound hearing loss, hearing aids will not be much of a help, although we always start with hearing aids. We let them try hearing aids, but for most children with profound hearing loss, they would need cochlear implants.
Okay, there's another question, Rina. How can we make the newborn hearing screening be more accessible to the general population?
That's a very good question. To make it accessible, then it would be good if it was free. If PhilHealth will cover all babies, regardless of their social status or ability to pay, if it is free for all, then I'm sure coverage will be improved. Also, information or education of the community. Sometimes parents do not believe that their children have hearing loss, which delays the diagnosis of these children. So it's good to have this information dissemination or educational brochures to give away to inform the parents and educate them.
Okay, another question, Rina. What is the current compliance rate of hospitals regarding universal screening? Compliance rate.
Yeah, so you're asking, your question would mean how many hospitals are complying with universal newborn hearing screening. This study is being done by Dr. Chip Recalde. We did a pilot study on 9 hospitals. 2 hospitals there did not want to participate, no? And another 3 did not complete the pilot study, and I think about 6 or 5, 4 or 5 completed the study. So this tells us that there needs to be political will, or it should be mandated from the hospital administrators themselves to push also for this universal newborn hearing screening in these hospitals.
And another question, Rina, is what type of hearing test machine is usually used here in the Philippines?
Because it is quite cheap, the OAE or autoacoustic emission machine is the one more commonly used, not the AABR. But as we know, AABR will give you a lower refer rate. So with that knowledge, I think more hospitals now are going to procure AABR machines.
Thank you. And how much do you need? There's another question. For hearing aids, how much do you need for hearing aids?
There's a wide range of available hearing aids, from about 30,000 to 100,000+, depending on the need of the patient. Usually those with mild hearing loss the hearing aids for mild hearing loss would be cheaper than those for profound hearing losses. And however, there are free hearing aids being given also in the PGH, Philippine General Hospitals, and other institutions as well.
Okay, Rina, this is a very good question. Is there a penalty clause for non-compliance with RA 1979?
We have discussed that previously in the Philippine National Ear Institute, and there will not be any penalty. They're thinking of maybe one way of encouraging newborn hearing screening would be if you have it done really early and you follow and you obey the law, then you would be allowed for maybe in the future for free hearing aids or free diagnostic tests, which will not be given to those who did not have their universal newborn hearing screening as stated by the law.
Okay. We have another question, Rina. Good day. I just want to ask if how about those newborns in the hard-to-reach barrios? Have we reached them?
That was one of the issues that I mentioned previously, that we need to address those individuals, for example, those born at home or those born in the far-flung areas. And we are devising in the PNAI a way of performing that, especially with internet connection and with cell phones being very common. Maybe through that means, we can reach all the babies who are born. Also, we have this BAT test, wherein a calibrated sound is given to the baby's ear, and then if the child startles, then the baby would pass the test. But this will not be covered by PhilHealth.
Well, this question, I'm not quite sure about this question, but is there a movement to create a law requiring newborn hearing screening, just like in newborn screening? I don't quite understand the question. I think there is a law already.
Yes, there is a law.
Yeah.
9709, which requires that all babies born be tested for hearing loss.
Okay. And for those who can't afford, what happens to people who cannot afford?
That's why it's very important to be covered by PhilHealth. And also there are some institutions who help these groups of people to have their hearing tested. They are the ones taking on the cost of the hearing screening test.
So what can another question is this, what can a patient do if there is no facility for a newborn hearing screening where the baby is born, or the baby is born outside of a health facility?
Okay, so if there's no access to any newborn hearing screening means, then we can fall back to the high-risk indicators. So for those individuals there, those who with high-risk indicators would be the ones really needing newborn hearing screening.
Okay, Rina, there's another question. Good day. Are hospitals mandated to comply with the newborn hearing screening in the country, or is this simply an optional add-on service?
No, this is really in the law. All babies really require newborn hearing screening. All babies born.
Okay. And how much is a newborn hearing screening test?
The PhilHealth is 200 pesos, and the test is in public hospitals. It is about 300 to 400 pesos. In government hospitals, in private hospitals, it might be 700 or 800 pesos.
And how can we make the implementation of RA, I think she's referring to 9709, mandatory for birthing facilities and hospitals?
The question is
how can we make it the implementation?
Okay, first we have
mandatory.
to know that there is a law mandating universal newborn hearing screening. Number two, we have gone to Luzon, Visayas, and Mindanao, the PNEI team, to train those who are supposed to be screened. DOH has disseminated the information. So I guess we just have to be informed and ready to be trained to do screening.
Okay. Another question, is there a catch-up hearing screen before a child enters school, for those who were missed at birth? It's a good question.
Okay. As of now, there is still no protocol for that. It's still in the works with the Philippine National Ear Institute. But in the United States, there is, I think it is required that all those starting school, preschool, and every year thereof until the grade 3, I think it is required, hearing screening is required. Also because at those ages, acute otitis media and impacted cerumen is quite common. So it's to catch these other disease entities also.
Another question, Rina. Are there untoward effects from newborn screening? And the second is, what is the false positive rate?
Untoward effect, if it is done properly, there should be none. Babies are tested, especially those who are in the NICU. They are tested when they are well, ready to be discharged. And I haven't heard of any untoward event occurring due to universal newborn hearing screening. Regarding the false positive
rate, yeah.
It's maybe quite low, maybe 0.01%, quite low. Yeah, so.
Okay, another question. Rina, should the school require a hearing test before school entry?
Yeah, I think that's very important. I think prior to school, my opinion is that a hearing screening should be done so that if there's any problem, there will be early intervention if there is a need. And if there's speech and language delay, then we can know if it's because of hearing loss or because of other problems.
Yeah, you answered the false positive rate. What about the false negative rates? That's another question. And what's the retesting protocol for that? I think you mentioned that in your lecture.
Yeah, I did mention it in my lecture. So false positive would mean that you would mean false positive would be there's no problem, but the tests show that there is, right? So that would be about 0.04%.
Okay, are there more questions? Okay, if there are no more questions, then Rina, I'd like to thank you for this very comprehensive discussion. Thank you also to our sponsors for today, to today's webinar, MedL. And as a summary, we learned that newborn hearing screening is very important. And I'd also like to reiterate that early diagnosis at the age of 3 months and early intervention at the age of 6 months are extremely important to work. And with the passage of the Newborn Hearing Screening and Intervention Act, we're moving closer to having a comprehensive program here in the Philippines. So thank you very much again to all our participants.